Well, thank you for that very kind introduction, and I'd like to thank Dr. Lang in absentia and Dr. Rigglein for the kind invitation back to talk. So today, in the next 40 minutes or so, I will talk to you about the normal TEE examination. There's a boatload of things that you might be worried about that they could ask on an exam. But I'm going to try and, as one person who passed the exam and at least 2 subsequent recertifications, I'm going to highlight the types of questions that you're going to see, or at least that I've seen on several exams. And I have no financial disclosures, and I've tried to obscure all equipment and names, etc. So we've already heard from Dr. Patil that there's the transthoracic echo is really a robust, portable, non-invasive diagnostic tool that can show us an extraordinary amount of information on a wide number of structures, including the right and the left heart, the valves, the aorta, and we can even see some masses at times. However, transthoracic echo has its letdowns. In cases of poor acoustic windows, perhaps in an obese patient such as myself, or extremely underweight person with very narrow rib interspaces, poor transmission of the echo image may prevent us from seeing the subtle findings that we really need to see when we're trying to assess valves and regional wall motion, etc. Hyperinflated lungs and COPD, something that seems to be very common in my echo lab at Temple up in North Philadelphia, a lot of obstructive pulmonary disease, frequently prevents seeing things to the resolution that we would like. Even in a patient who has ideal windows, who makes beautiful pictures, structures less than 3 millimeters may not be visible, especially if they're highly mobile, on transthoracic imaging. In addition to the fact that there are certain structures that just are conveniently hidden from transthoracic imaging for the most part, although you can occasionally see a left atrial appendage. If you really want to evaluate it, you will need TEE. Pulmonary vein morphology and flows are oftentimes best assessed on TEE, and a complete aortic examination, that which will be allowed by the trachea and shadowing of that, is also best done with a TEE or other modality. And of course, we'll be hearing on Monday from Dr. Sarek the vast number of applications of both 2D and 3D TEE in terms of procedure guidance, where the typical transthoracic imaging windows are typically under sterile drapes and or interventionalists' fingers. So these are really where transthoracic leaves and TEE comes to the fray. Now, when our lives as non-invasive cardiologists become dull, we always know that deep down inside there was a craving to be interventionalists of some sort. And so TEE really is not interventional, but certainly invasive cardiology. By extending this probe, which is a modified gastroscope with an ultrasound array at the tip, down into the esophagus, the close relationship between the esophagus seen here and the left atrium seen here, they are intimately opposed to one another, typically with no fluid or very little fluid, and actually fluid is okay because you're able to, it actually transduces the ultrasound better. There's no lung tissue between the two of them. We can get very close up and pristine images of the heart. Okay. Really, sort of the go-to manuscript here is potentially getting a wee bit elderly, I guess, in terms of the publication dates. but I don't think the heart or transesophageal echo has changed in the last 6 years. And Dr. Rebecca Hahn et al.'s really Bible-like manuscript regarding transesophageal echo should really serve as your reference point, mostly from your clinical activity in the lab, but also potentially for your exam taking. So I highlight that here, and if you don't have a copy on your laptop, I would suggest that you get it. So there's a myriad of indications for TEE. Obviously, we've said when the transthoracic is non-diagnostic, particularly when the findings could be critical to the treatment of the patient, when we want to see the left atrial appendage up close and personal, assessment of the thoracic aorta, which we are not going to see well on transthoracic, small structures, etc. Or in specialized populations, some people advocate the use of TEE for emergency diagnosis of critical lesions in the critically ill, for procedure guidance, which again we will hear about a lot from Dr. Sarek, and also for intraoperative monitoring of cardiac surgery, including valves and risky bypass, and sometimes in terms of non-cardiac surgery if there is a cardiac issue that may be changed intimately during the operation, TEE is indicated. So, having the indication doesn't necessarily mean that we could just ignore the potential ramifications of the procedure. And there are many potential complications of passing a blind probe into the esophagus. And these are fair game on the exam. There will be questions. So just beware that there is the potential for oral trauma, both of the lips and the teeth. Loose teeth are not a happy feature, and typically we require dental consultation. Pharyngeal laceration, creations of hematomas, or even perforation of the posterior pharynx, tickling the larynx with laryngospasm, or even vocal cord trauma have been reported to occur. Accidental tracheal intubation you need to be aware of, as well as esophageal perforation and laceration, entering an unexpected diverticulum and causing potential problems, and even in the stomach, laceration and perforation, while they may be less likely, still can occur in the frail or decompensated patient. You need to be aware that aspiration, both simply a chemical aspiration that may cause transient desaturations, or an aspiration that introduces bacteria and results in an aspiration pneumonia, are also potential complications. These may be sedation related. Simply, you don't have to become hypoxemic from an aspiration. Just simply over-sedation and under-ventilation can lead to hypoxemia, hypercapnia, and airway obstruction. We have to be aware of the potential for thermal injury as well as electrical injury, which sort of falls into this category. Allowing the probe to heat up too high. Usually the probes will self-stop imaging, but sometimes if it's sort of teetering at the brink of a high temperature, and you're imaging for a long period of time, you can cause esophageal and gastric burns, which may result in bleeding and perforation. So you should always watch the temperature of your probe and freeze early. Freezing the image stops the imaging and allows the temperature to decrease. There are indeed pressure-related problems. When you have a probe in during an operative procedure, or when you have a probe in perhaps for a long procedure for a paravalvular leak closure, and you leave that probe in the esophagus in a anti-flexed position or retroflex position, that constant pressure for hours, whether or not you're imaging or not, can cause a pressure injury. And that can lead to perforation. So if you're not using your probe during a surgery or during a procedure, it's best to advance into the transgastric view and leave the probe in a non-antiflexed and non-retroflexed position. So while this may sound dire, we are very lucky that overall the general complication rate for TEE is very low. Those serious complications, such as morbidity, bleeding, and bronchospasm, are on the order of less than 0.1%. And overall, even minor risks are not all that common. But when we're consenting the patient, we need to make sure that they are aware of these issues. Other test-worthy questions: absolute contraindications for TEE. Again, there may be some hedge room on this. There's some equivocation in some documents. They're not going to go after minutia. They're going to go after big things. So just to be aware, you should think of these. Any overt esophageal pathology, a known stricture, a known diverticulum, a recent Mallory-Weiss tear documented, scleroderma, particularly scleroderma associated with any kind of dysphagia, but some even, including myself, consider scleroderma, even when it's cleared by GI, to be a contraindication due to the easy friability of the esophagus in these scleroderma patients. I really don't want to be putting a probe down unless it's absolutely necessary. Tumor and trauma to the esophagus, known perforations of the esophagus or stomach, recent or active GI bleeding, including hematemesis and melena, and some would extend that into an unexplained drop in hemoglobin where there is no other obvious explanation. You might want to get your gastrointestinal colleagues to come and do an EGD to rule out esophageal or gastric pathology. I would say any gastric surgery. I mean, obviously, if there's no esophagus there's nothing to do put a TEE probe into. A bariatric procedure, even a fresh one in particular, and those status post-esophageal gastrectomy are not really ideal. And unstable cervical fractures are typically considered absolute contraindications. More relative contraindications are those that you need to be aware of and think about, because frequently you can do a TEE in these situations, but you might want to activate your colleagues, either gastroenterologists, hematologists, or maybe your anesthesia colleagues, in terms of evaluation of lesser upper gastrointestinal disease. Grade 4 varices, obviously I don't think anybody wants to be doing a TEE, but if a patient has recent documented grade 1 or grade 2 varices that are not bleeding, it's pretty safe to do a TEE. But even if you go ahead with these relative contraindications, you should always notify your patient of the increased risk. Okay, indications, contraindications lead me, unfortunately, to appropriate use criteria, which tend to make me nauseous when I think about, or nauseated. Dr. Origem keeps me on my toes with my English. I may be nauseous to you, but appropriate use criteria make me nauseated. Basically, what I've tried to do in this slide and the next one is to do the majorly appropriate and the majorly inappropriate criteria, both from Dr. Douglas's original AUC echocardiography, but also from some more recent multimodality imaging criteria. There is actually yet another appropriate use document which sort of hits on some aspects of TEE that just came out this week in JACE. Your exam is in July. The exam was made in November, so you're not going to be, first of all, you're not going to be questioned on little nitty-gritty microscopic stuff, and you're not going to have to worry about that recent 2019 document, so I'm not even talking about it here. In general, focus on appropriate and inappropriate. Don't fret a lot about undetermined appropriateness or maybe appropriate criteria. So in general, those that are appropriate, The appropriate use for initial evaluation use of TEE is suspected endocarditis with moderate or high pretest probability, cultures, as well as a new murmur. And it's actually considered appropriate as an initial test for evaluations of cardiac masses, suspected thrombus or cardiac source of embolus, although frequently we'll see transthoracics being done as a preliminary screen. As additional testing, again, for a non-diagnostic TTE or inadequate TTE images where the information you need to change diagnosis is going to be important. Look for those buzzwords where, you know, your TEE will find out information that will actually change your diagnosis or change your plan of treatment. Those are going to be the buzzwords that are going to say, that's going to have to be appropriate. So these are some selected appropriatenesses. Actually, along those lines, assessment of the severity of mitral regurgitation, sometimes just if you're looking for severe, but even looking for moderate to severe, it can be very difficult on a transthoracic echo and may be underestimated. And TEE not only gives you the morphology of MR, but also may help you qualify the severity, although there too, the loading conditions may lead you to underestimate severity as well. But take a look at these and kind of commit these to memory, and their counterparts here are the inappropriate criteria. And again, things are sort of obvious. Use of TEE when transthoracic is diagnostic. Why would you put a patient through a transesophageal when a transthoracic is diagnostic? But just Friday, before I left work, they were having an argument with a cardiothoracic surgeon over he wanted a pre-op TEE when all the diagnosis was there on the transthoracic. So these things come up, and just be aware of them. So I've listed sort of the highlights there, and that's really for memorization. Be aware of the preparation issues, NPO for about 6 hours prior to the study. Make sure you have peripheral IV access. Obviously, you need it if you're giving conscious sedation. Always risk stratify, particularly important using the Malampati grades in class. The Malampati looks at the visualization and the ability of the patient to maintain an unobstructed posterior pharynx. Class 1 here, you can see the posterior pharynx quite well. Class 4 here, the tongue and the pharyngeal tissues obstruct visualization, and as we go up from class 1 to class 4, you have an increasing risk of obstruction. I'm not saying that that's an absolute contraindication, but if you have a person with class 3 or class 4 Malampati score, you may want to get your anesthesiologist involved to help you out, and it might not be the best time for you to be doing your own conscious sedation, but clearly class 1 is a go-ahead. Make sure you have your airway equipment, blood pressure and vital signs monitoring, and there's requirement for an ACLS support equipment and at least one certified participant. Moderate conscious sedation is the rule of the day, and there will be questions on this. Moderate conscious sedation includes both topical anesthesia with benzocaine, lidocaine, or viscous lidocaine. You should be always aware of the posterior pharynx. You should always be aware that there is a small risk of methemoglobinemia, defined with benzocaine in particular, but it's very rare. But if the patient, becomes hypoxic, that is something to be conscious of. Conscious sedation obviously involves small incremental doses of short-acting benzodiazepines and opioids for a synergistic effect. We tend to use propofol in our lab, but we have this administered by anesthesia. Always have your reversal agents, including flumazenil and Narcan, available. And remember to live a life of moderation. The goal for the TEE is moderate conscious sedation. The patient should have a purposeful response to verbal and light tactile stimulation. The airway is going to be affected but should not require intervention in terms of sort of oral airways or potential intubation. Spontaneous ventilation should be adequate. And if you get any deeper than that, you've gone into undetermined territory and dangerous for the patient. So moderate sedation is the goal. And so you should know these criteria for what classifies as moderate sedation. Some special conditions to be aware of in ventilated patients in the ICU. I still recommended to use topical anesthesia in the posterior pharynx, as well as a bite block, because they may or may not be all that adequately sedated. We want to protect their teeth and protect your probe. Varying degrees, be aware of sedatives may already be on board, so you have to count that into your consideration. And you're always being careful to avoid dislodging the endotracheal tube. Always remember that the naso or orogastric tube may get moved around, or it may require to be removed entirely, but at the very least needs to be rechecked at the end of the procedure. So our TEE probe, we've got it in there. The patient is moderately sedated. They're maintaining their consciousness to a degree that's appropriate. Now let's switch to the probe and the imaging itself. The probe is remarkably movable. We have anterior flexion or anti-flexion, as well as posterior flexion or retroflexion, usually controlled by the larger knob of the various manufacturers' probe. We can flex to the right or flex to the left, usually controlled by the smaller knob of the various manufacturers. Or you can actually rotate the whole apparatus clockwise and counterclockwise, as well as withdraw, pull out, or advance, push in. And electronically, we can vary, because now most of our probes are omniplane, we can sweep the plane of the imaging throughout a 180-degree view. The 2013 ASE TEE guidelines outline 28 views for a complete TEE, and Dr. Hahn, I know from personal experience, is extraordinarily brilliant and extraordinarily compulsive and thorough individual. And so those 28 views pretty much cover every base of the TEE that you could possibly want to know. Do we need to know all these images, all these views specifically for the exam? Probably not. I'm going to highlight in the next couple of slides some of the common images that you're going to see, and those are the ones that I would focus your attention on. We're going to focus a lot on the mid-esophageal and transgastric views, because that's where you get most of your information. But be aware that being in the stomach and going into a deep transgastric view far out at the apex, by pushing the probe far out to the apex, can actually be very useful for specific indications. And also doing imaging in the upper esophagus, particularly at the level of the great vessels, may also be used. And also remember that although we may define these specific views, cardiac rotation and twisting and other deviations may very well alter what planes you need to use in any one individual patient. So don't fixate on, in clinical life at least, on, oh my God, it's 60 degrees. I have to be seeing this at 60 degrees. Why am I not seeing this at 60 degrees? What you're going to get on the exam are going to be the standard type stuff. So this is just the list of the multitudinous number of both the esophageal views, and here we can see just an ongoing list. Just be aware that the mid-esophageal views are usually used for the evaluation of the valves themselves, as well as the left atrium and left atrial appendage and the pulmonary veins. And again, these are all available online very nicely. There's a cartoon. There's sort of a cartoon of how the imaging is slicing. There is a picture as well as a linked AVI. And then they tell you the exact transducer angles, etc. Do I think you need to memorize all this for all 28 views for the test? Absolutely not. But be aware that they're here. The transgastric views obviously are focused on evaluating the left ventricle, both in short axis and in long axis. But using deep transgastric views, we can also look back at the aortic valve, both in long axis and in short axis. So, and the upper esophageal views are typically used to look at the aorta and the pulmonary artery. So let's look at some of the views that you're very much more likely to see on the exam itself. These are all mid-esophageal views that I'm about to show you. This is the mid-esophageal four-chamber view. It is typically acquired between 0 and 20 degrees of omniplane, and we can see all four chambers: left ventricle, left atrium, right atrium, and both tricuspid and mitral valves. This is very good for assessment of MR and a little bit good for assessment of TR. We get an idea of how the ventricles are contracting, although you can have foreshortening of the LV. But this is your standard four-chamber view, 0 to 22 degrees in the mid-esophageal area. If we clockwise rotate and insert just a little bit, we get a slightly better view of the tricuspid valve. And so this is sort of an off-axis four-chamber view, focusing on the right ventricle, the tricuspid valve, and the right atrium. Here's color flow Doppler with a normal mitral valve, so no regurg. The mid-esophageal two-chamber view is typically between 90 and 100, sometimes slightly over 100 degrees. What you're seeing here is left atrium and left ventricle. Use your landmarks. You have the coronary sinus here, so this is the inferior wall here, anterior wall is here, anterior leaflet of the mitral valve, posterior leaflet of the mitral valve. In an angle of about between 45 and 60 degrees in the mid-esophagus, we get the mid-esophageal short-axis view of the aortic valve, and this looks a lot like the short-axis view of the aortic valve on the parasternal short axis, except we're going from the inside out. We can see the tricuspid valve here, the pulmonic valve here, but we see a very nice aortic valve. This is the non-coronary cusp attached to the interatrial septum. This is the more anteriorly directed cusp, which is right next to the RV. So this is the right coronary cusp, and the right coronary artery would originate somewhere here. And you can see the left main artery playing back and forth with the translation of the heart here. That is the left coronary cusp. So that is the mid-esophageal short axis view. If we rotate to sort of a mid-esophageal three-chamber view or a mid-esophageal long axis view of the aorta, we get the aortic valve in long axis as well as the proximal portion of the ascending aorta. And we can also apply color Doppler, obviously. Now, you're going to hear a lot about the mitral valve tomorrow, I believe, from Dr. About Dr. Mankat. I'm having word-finding difficulties. Along with my reading glasses, it's a sign of my progressive senility. But Dr. Mankat is going to cover this in great detail, the trans-esophageal views, especially the 3D view of the mitral valve. The mitral valve, as you know, consists of a larger anterior leaflet, a more rectangular posterior leaflet, and each leaflet has three segments or scallops stretching from lateral next to the left atrial appendage, A1 and P1, all the way over to medial, which is closer to the tricuspid valve, A3 and P3, and then you have A2, P2, which is known as the middle segment. Medial segments, middle segment, or A2, P2. This is a bugaboo of my existence, at least early on in my career as a transesophageal echocardiographer. But on every exam that I have taken, and I don't know if Dr. Urajema or Dr. Patil have shared this, I have been shown 2D images of the mitral valve, and I've been asked to identify which of these cusps. So this is really something that you should probably commit to memory and just take a look at. Starting with the mid-esophageal four-chamber view, 0 to 20 degrees, we have the mitral valve, and predominantly what you're seeing is A2 here and P2 there. Dr. Hahn, in her meticulousness, says that you may be seeing part of A3 there, but that makes sense because it's right next to the tricuspid valve, and you may be seeing a piece of P1, the lateral part of the posterior leaflet over here. But remember, A2, P2 for the four-chamber view. The mid-esophageal or mid-commissural view, sometimes known as the intercommissural view of the mitral valve, at the 45 to 60 degree omniplane, you are basically seeing three leaflets, and it's rather unique. You're seeing P3 farthest to the left. You're seeing A2 for the most part, especially when it's disjointed and it seems to separate entirely. You're seeing A2 and you're seeing P1. Again, the left atrial appendage is popping in and out here, so you know you're lateral, and you have coronary sinus, so you know you're medial. So P3, A2, P1, a favorite image to show on exams. The mid-esophageal or two-chamber view, the mid-esophageal at 90 to 100 degrees, you are seeing basically A3 and P3. You may be seeing a little bit of A2 and a very minuscule bit of A1, but again, remember A3, P3. And then when we get to the mid-esophageal three-chamber view, what you're going to be seeing there is largely, again, A2 and P2. Okay? So just remember those things because they do come in from importance. As I've mentioned, the TEE is very important in terms of the assessment of the left atrial appendage. The left atrial appendage is seen here in the 90-degree view, but we can visualize this in multiple views, obviously. And this is very important in terms of ruling out cardiac source of embolus, as well as evaluating for cardioversion or other electrophysiologic procedures. Here we have no evidence of thrombus present. If we pull back just a little bit, withdraw the probe just a little bit, and antiflex just a little bit, we can see better the left atrial prominence here, which is sort of the fold of tissue between what is the left upper pulmonary vein here, that red inflow there that you're seeing, and the left atrial appendage, which is down here. We're not seeing the left lower pulmonary vein, but that would usually come in somewhere along here, and it's a little bit more, the flow is a little bit more perpendicular to the flow, to the imaging probe. We can Doppler the pulmonary veins here, and this becomes very important when we're assessing the severity of mitral regurgitation. This is a normal Doppler flow pattern with a predominant diastolic component, a predominant systolic component, a lesser diastolic component, and a very small atrial reversals. In the 90 to 110 degree view, if you clockwise rotate from the sort of two-chamber view, you are going to get what's known as the bicaval view. This is a very important view for assessing the interatrial septum in the region of the fossa ovalis here. We can see the septi and the area of where a patent foramen ovale might be. We can see the superior vena cava here, and unfortunately the inferior vena cava is cut off in this view, and this is really the part of the right atrial appendage here. Here's one where we did a bubble study, agitated saline contrast, to look for any right to left communication, and there was none. So those are some of the structures that you may see on exams, and you should be aware of what view those are. The classic transgastric view is a transgastric short axis view. I display for you here the short axis 0 degree plane in the transgastric view of the LV at mid-ventricle. either by withdrawing or inserting, advancing the probe. You can move from the mid-esophageal, withdraw slightly to the, you can mid-papillary muscle. You can withdraw to show the sort of the mitral plane, typically with a little bit of anteflexion, or you can advance and retroflex and drop the heart down and see the apical short axis. So manipulating the probe can move you through the left ventricle and short axis. And again, we can use change the plane to 90 degrees and basically get a transgastric long axis view with the anterior wall, anterolateral papillary muscle, and inferior wall of the heart here, anterior leaflet, posterior leaflet of the mitral valve. You can even see the left atrial appendage peeking in here, although that's not a guarantee. Another view that you may be shown and that you should recognize is the deep transgastric view. This is about as good as we can get in terms of assessing gradients and flow across the aortic valve as well as across the pulmonic valve. If you advance your probe out very deep into the gastric space and you antiflex very sharply, your probe is basically wrapping around the apex of the ventricle, and you are basically taking a picture that is approximately similar to an apical 4-chamber or an apical 5-chamber view. Here is a deep transgastric looking at the predominantly at the aortic valve. We see the LVOT here. We see the mitral valve here. The LV is very foreshortened, so you really can't assess function here, but we're mostly interested in potentially looking at flow either in the LVOT or across the aortic valve. If we torque this a little bit to the right, this is the RVOT right here, and the pulmonic valve is sort of a little bit more anterior. And so we're not seeing the pulmonic valve in this view because we're seeing the aortic valve. You're not going to see them simultaneously, but you can twist this view so that you can actually see the RVOT better, as well as a straight shot down the RVOT to the pulmonic valve. But just be aware that this is the deep transgastric of the aortic valve and the proximal aorta here. And this is an example of somebody, you can see the very calcified aortic valve here. We're way out at the apex looking backwards, and with continuous wave Doppler, we can actually measure quite a nice Doppler profile. Special applications of TEE, you're going to hear about these a lot from Dr. Sarek later in the week, as well as some 3D imaging from Dr. Lang and from Dr. Mankad. So you should have familiarity with them, but they're not going to be asking you questions, showing you a picture and saying, is this mitral clipping device in an appropriate position to grasp? They're really looking for broad concepts. So fret not over the minutia. And so we're going to see a lot of this later in the week. So I think I'm going to rapidly bring this to a close so that we stay on time. This is just an example of simultaneous multiplane imaging of the left atrial appendage, here at 60 degrees and 150 degrees. This is an orthogonal view, 90 degree from one another. We can do multiplane imaging of the superior vena cava here. Now we've swept the image a little bit off axis, so we're seeing the longer axis of the SVC here. Here's a simultaneous multiplane view of the transgastric. And then again, 3D TEE imaging, I'm going to leave more to the interventional talk and to the other lectures, but be aware that interventional echo ASD closures, both for sizing of the device and after placement of the device, both 2D and 3D TEE imaging is useful. We can use 3D imaging to really get a very accurate planimetry or assessment of mitral valve stenosis. by being able to position our planes precisely at the actual orifice of the mitral valve. So that's an important application. Both 3D and 2D imaging can be used for mitral valvuloplasty. And obviously, there's been improvement here after the balloon inflation with a reduction in gradient. Interventionally, echo, transesophageal echo, particularly this sort of orthogonal imaging is very important for transseptal procedures. We can visualize here in the 60-degree plane the aortic valve, which is anterior. This is more posterior, so we can tell our interventional colleagues, yes, your transseptal catheter is positioned right at the posterior margin of the thin part of the septum, and using a subsequent image over here, simultaneously, we can tell them that it's sort of more inferior. This is would be more superior, that's more inferior. So he's inferior and posterior, and that would be appropriate for certain procedures. Here's 3D imaging for a MitraClip, and frequently for TAVRs post-op to look for paravalvular leaks immediately post-op, not necessarily all the time, and of course for placement of left atrial appendage occlusion devices, as well as leaks for paravalvular plugs for paravalvular leaks. Here we see a leak around a paravalvular leak around a bioprosthetic mitral valve. The wire is put through that leak using 3D and 2D guidance, and then the paravalvular leak is subsequently closed. So, in summary, what do I need to know for the exam? You need to know indications and contraindications. You need to know the major appropriate use concepts. Don't focus on the uncertain appropriateness or the maybe appropriates. Function on the A's and the I's, the definitely appropriate and the definitely inappropriate. There will be questions on patient evaluation and preparation, as well as complications that are both probe-related and sedation-related. Know the major views and structures using the 2013 guidelines as your guide, and I would recommend memorizing the mitral valve segment identification on 2D image planes, as well as you'll see it a lot on the 3D image planes when Dr. Mankad gives his superb lecture. And we will hear later on Monday from Dr. Sarek about how it's used for interventional procedures. So I thank you for your attention. And
Marty,
yes.
Excellent lecture as usual. While Dr. Cronson makes it up to the podium, there will be there were a number of questions on scallop identification.
Yes.
I have two comments about that. One, hold on to those questions until after Dr. Mankad's lecture, and Marty will be around also. I think between the two lectures those questions should be cleared up. I also think that in this age of omniplane and 3D, that a lot of the scallop identification that you need clinically it's really a moot point, because especially if you use your biplane imaging, you pretty much can nail the affected scallop. Yeah. The questions I did want to ask you, Marty, were procedural. There are a lot of these. Talk about people with coagulopathies. What INR would you consider to be a contraindication, and what about platelet counts?
Yep. Well, I mean, I typically, everybody's a little bit different, and that's why we talk about relative contraindications. And obviously this is going to vary from any particular patient. I mean, if I have a patient who's he's on anticoagulation and they have a normal normal blood counts, they have normal platelets, and their INR is 5, I'm not that worried about going down and doing a TEE. If I have a patient whose platelet count is 20, who has known esophageal varices, even though they're grade 1 and they have an INR of 5, well, then I'm really nervous. So you have to sort of put everything into perspective. They are not going to ask you on the exam, I don't think they're going to ask you, like, what is the level that you need to cut at? Because it really is patient specific, and you may, and it's actually, and I think it's operator specific. But I mean, I think the INR has to be looked at in terms of sort of the other milieu of the patient's clinical status. Platelets, I've heard people say, I won't do a TEE less than 50. Other more renegade colleagues will say, I'll do it at 20. I don't have too much of a problem doing it at 20 myself. But again, you will find people who say never below 50. I'll never do a TE below 50.
One last question, just in the interest of time. Infection control at our institution is recommending that you use a sheath for TEE to lower the risk of HPV transmission. This is not an issue we've faced. I imagine something like this might come up at your institution?
Maybe. It hasn't yet. I mean,
okay.
There's a big focus, obviously, on probe sterilization, and we have keep the cleaning machines up to the latest guidelines, and they're brand new, and we clean the probe like several times with several different agents. So, but I've been told nobody's come to me and said we need to do a sheath yet.
Okay.
That could be interesting.